that's most of the waiting room in. And so with that, I will say good morning and welcome. I am Sarah Weatherson, she, her. I'm a white woman with gray and brown hair and glasses. And I'm lead staff for the Medicaid Advisory Committee, or the MAC, and this is the MAC's public meeting for September 2025 to help fulfill its state and federal mandates to advise both the Oregon Health Authority, or OHA, and ODHS, that is the Oregon Department of Human Services, on how to run the Medicaid program. And so I'm going to share a few logistical announcements before we get started. We're going to ask folks to mute yourself if you're not speaking. If anyone is joining by phone, we'll ask you to mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you have to leave, it's better to hang up and rejoin the meeting. And then for MAC members, we'll ask you to use your raise hand button if you have a comment or a question, or please put a note in the chat to let us know you're ready to speak. So the Medicaid Advisory Committee has built in time for discussion after each presentation, and we'll have the MAC members speak first. If there's any time remaining for an agenda item, we may take general questions. We also have 10 minutes for public comment near the end of the meeting. Let's see. We do have ASL and Spanish language interpretation available for today's meeting, and you can pin the ASL interpreter's video by clicking on the More button next to their name. There's also a button for interpretation, which is where you'll find the Spanish language interpretation at the bottom of your Zoom screens. And with that, I'm going to hand it off to our MAC co-chair, Caroline Barrett, to take us through our meeting.
Good morning. Welcome, committee members and members of the public. I'd like to welcome our newest member, Lydia Denny. Am I saying your last name correctly?
Dennehy, but yes,
Dennehy.
very close.
Thank you.
Thank you.
Our roll call is going to be a little different this month. This month is the first time we have met since the federal access rule went into place. There's a new requirement that members must declare any conflicts of interest at the start of each meeting. No definition of conflict of interest in the federal rule. If you feel that anything in your personal or professional life creates a potential conflict of interest for your work on the MAC, declare it when your name is called. So I'll start our roll call. David Lima. I'll circle back. Director Emma Sando.
Here.
Co-chair Heather Jeffress.
Present.
Heather Procho, and I apologize if I'm saying your last name incorrectly as well.
No, Jeffress, like Ferris wheel. You did a perfect pronunciation.
I'm sorry, I meant I apologize. I was reading Hillary's name and then said that as I was reading Hillary's name. I apologize, Heather. Hillary Procho.
Hey, I'm sorry, Caroline. Hillary did send us a note this morning that she will arrive at 10 a.m.
All right, thank you. Kelly DeVore.
Morning, present.
Ronnie St. John. Shannon Buck. Stacy Shaw.
I'm here.
Shannon, you're here. Great. Thank
Yes,
you.
I am. As far as
morning.
conflicts of interest, I am a birth doula, so anything having to do with that, I would obviously be very pro doula.
Thank you for sharing that. Stacy Shaw.
Present.
Jerry Weeks.
Present.
Kaya Adams. Dr. Tony German.
Present.
Peter Starkey.
I think we have heard that Peter is not going to join us today.
Okay, and to circle
I don't know
back,
if you heard me, Caroline. Sorry. This is Kaya. I said present.
Oh, I did not hear you. Thank you. Great. Thank you, Kaya. And David Lima, are you here? And Ronnie St. John? Sarah, do we have a quorum?
We do have quorum.
Thank you. Committee members, last week you received draft minutes from our most recent regular meeting, which was in June. To review, please take a moment to review the minutes for any errors or omissions. Do any committee members have concerns about the minutes? If there are no revisions, I also want to call attention to the consent agenda, which you also received prior to this meeting for review. Do I have a motion to approve the June meeting minutes and to acknowledge our consent agenda?
This
Kelly,
is He-
I'll make that motion.
I apologize. Who was that made the motion?
Kelly.
Kelly, thank you. Do I have a second?
This is Heather. I'll second.
Thank you, Heather. Any objections?
No.
Any abstentions? I will abstain as I was not at the June meeting.
This is Lydia. I will abstain for the same reason.
The motion carries. So we'll move on to our next agenda item, moving on to our Medicaid Director update. Today, Medicaid Director Emma Sando is joined by Health Policy and Analytics Director Claire Pierce-Robel. And so I will pass it off to Director Sando and Claire Pierce-Robel to speak on their update. Thank you very much for being here today.
Thank you so much. Thank you everyone for having me here today. This is amongst my favorite meetings to attend in the thousands and thousands of meetings that I have every week. So I appreciate you all so much and the work that you all do to make sure that our Medicaid program is working for the members that we serve. We have a number of updates here in around HR1 more broadly that Claire and I will walk through. I think one thing that we have heard is a little bit of also overview of some of the other programs that people may have experience with if they are enrolled in OHP and how that is affected by the new changes that are that were passed into law on July 4th. I've given a couple overviews in previous meetings of some of these changes at a high level, but we'll be digging into these a little bit more. I do want to note that HR1 is not the only thing that's going on in Medicaid right now, but we're gonna focus on this first, and then I will provide a very high level of some of the other really larger issues that we're working on. But what I really want to draw your attention to is we started a new series of public webinars called Forward Together, where OHA folks from across the agency are providing some updates on various programs. And the next one is actually September 30th, so less than 2 weeks away, which somehow the end of September is less than 2 weeks away. That just gave me a little bit of panic of how fast time seems to be moving. That webinar, I would very much welcome both you to attend and share with any partners who are interested in knowing more about what's happening as part of the federal activity. As well as, I think I've been saying this for nearly a year now. We have a federal website that once I am not talking, I can drop in the chat, or somebody that is much faster at their computer than I am may be able to drop in the chat, where we are regularly posting updates on various things that are happening at the federal level as we know them. And so I encourage you to also share that with partners and other people that are asking questions about what's going on at the federal level, as those are some of the places where we have the most updated information. So that would be helpful for folks. All right. Sorry, this is me. For a second there, I was looking at the wrong slide deck and was like, next slide, but that was because I needed to start here. So I'm going to talk today about the HR1 more broadly as a reminder that I know that this team is well aware of. 1.4 million folks in Oregon are covered by the Oregon Health Plan. Including a half of all children in our state are covered by the Oregon Health Plan. In estimates, about $10 billion of Medicaid funding over the budget cycle could be lost in federal funding through a variety of different policies that I'll get into here. I will note that this is changes over a period of time, and there are policies in HR1 that both reduce Medicaid enrollment, which since the federal government matches the healthcare expenditures of folks, and this that leads to reduced federal funds coming into the Oregon state government and state programs and healthcare facilities. That also means that fewer people have access to healthcare coverage and fewer people are enrolled in healthcare. Next slide. Some of the policies that we'll get into here, where there are really significant changes, are related to ways in which we pay for the state share of the Medicaid program. Starting in 2027, there'll be a reduction in the ways in which we collect the state share of the financing of the Medicaid program, which will result in a rather significant reduction in federal funds coming into the state. We use some Medicaid funds to directly pay for various providers, whether that be hospitals or other programs that use what is known as directed payments. There's also new caps going into effect starting in 2028 that would reduce the state directed payments to those various institutions, and essentially put rather than using a measure of average commercial rate, would tie those state directed payments rather to Medicare rates, and that would result in a rather significant decrease to some of our providers and facilities. There is also a reduction in the federal amount that is used to pay for emergency services for people that would otherwise qualify for Medicaid, but for immigration status. And so for many of those adult members, if they use the emergency room, 90% of the funds are funded by the federal government and 10% are funded by the state. This would change that percentage to be what the regular state match rate is, rather than the 90% match that for certain adults that had been received prior, and that would have a significant impact on our state government, and that goes into effect in 2026. And we also have significant coverage reductions that I mentioned earlier, in part due to really two main policies. One is a reduction in people due to a new requirement to prove work and or community engagement, such as community service or looking for work. And that new requirement would, even if people do engage in work and community engagement, we would anticipate that
You can't
having
really tell
to
because I'm in a
prove
state
that.
meeting, but I just wanted to make sure you're
Oh,
okay.
I think somebody might be off.
No one said if they liked their stuff, so I'm getting.
Oh, great. And then additionally, we anticipate that people will have to redetermine, and a larger number of people will have to redetermine their eligibility on a 6-month basis rather than what now many people redetermine their eligibility every 2 years. And then additionally, there is a provision in the law that has creates a new a prohibited entity for certain providers. Planned Parenthood is in our state that provider for 1 year in which we cannot pay as a Medicaid program, Planned Parenthood. There has been a significant amount of legal activity in this space. And that is caused quite a bit of changes in this policy over the last couple of months. Next slide. So I apologize. I forgot to do the introduction of Claire Pierce-Robel. Claire, I don't know if you want to quickly say hello so people can see your face on the screen if they have multiple lines open, and introduce yourself.
Sure, happy to. Thanks, Emma. Hi, everyone. Good morning. I'm Claire Pierce-Robel. I serve as the Director of the Division of Health Policy and Analytics. And I'm joining you here today because Emma and I are working very closely together on the HR1 changes, which also have an impact on the Marketplace program, which sits under our Division of Health Policy and Analytics. So as we're going through some of these overview changes year over year, we'll kind of trade off speaking to the Medicaid and Marketplace provisions. And then we'll just also note that there's we won't be speaking to it specifically, but included on these slides are some of the impacts to SNAP that are happening at the same time. And so just wanted to take a moment to note that we are also working very closely with our partners at ODHS on all of these changes. And it's important, I think, to see in this way how these provisions are going to be impacting a lot of the same people at the same time. And so we need to be really thoughtful about how we communicate about that to members and enrollees, and noting that as there are changes to Medicaid happening, there are also these changes to the Marketplace program that are going to make it more difficult for those that are losing coverage to enroll and maintain coverage on the Marketplace side. And so this is really a reason to have an all hands on deck and comprehensive review across all of our programs, and just appreciate the opportunity to come share with you today what we're working on.
Thank you. So this presents the information that I just provided in a little bit more of a timeline way. So there are changes that are going into effect in 2025. First, new state-directed payments are essentially frozen starting in 2025, so that those decreases that are expected in out years, we don't see a significant increase right before those decreases. Also, the same goes for the provider assessments. And as I mentioned earlier, that Planned Parenthood covered services are also going into effect, or went into effect on July 4th. Claire, I don't know if you want to touch on the Rural Health Transformation Program.
Sure, I can speak to that here. It's not mentioned in the slides, but we can make sure to put a link in the chat to our page discussing the Rural Health Transformation Program. This is a program that was authorized under HR1 to fund states' efforts to support rural health transformation. CMS is issued a notice of funding opportunity this week, which we are currently reviewing and analyzing and assessing how Oregon will submit an application for that funding. We are expecting, if awarded, to receive $100 million per federal fiscal year for 5 years, which will be directed towards activities that we are allowed to fund under that program. And so further detail is included in the link that I'll drop in the chat. We also have a very short turnaround time as a state to apply for this funding. So it was just released this week, and we need to submit a very comprehensive application by November 5th. To support that, and just in recognition of the short window that we have, we did request public comment and solicited ideas from partners across the state over the course of the past few weeks. We received a tremendous number of responses, and so we are at the same time as analyzing the notice of funding opportunity, also looking at that feedback from the community to help inform our approach. And we would anticipate having another opportunity in the October timeframe before we submit the application for additional public input. So please stay tuned on that front. This will be something that we're working on very closely with community over the coming not just 6 or 5.5 weeks, as the case may be, but over the next 5 years. So I'll pass back to you, Emma.
Thank you. Here on the slide, we have what our ODHS partners shared on SNAP. We know that many people are who are enrolled in OHP are also enrolled in the SNAP program, and what this some of these changes do is require work requirements that have existed in the SNAP program starting in this month, and then also includes expanding that to additional individuals, and the reduction in utility allowances in the SNAP program. I want to also note that there are some changes to the refugee programs that will affect many of our members as well, in which they can receive some of these critical benefits, such as SNAP and other social welfare programs, and then changes to DACA as well on the Marketplace and OHP Bridge program. Next slide. In 2026, there will be a change in how we define qualified immigrants, that will mean that more people may be removed from Medicaid coverage, but that they may still be eligible for HOP coverage. Emergency Medicaid financing, I mentioned that earlier. And then also we have on here the work requirements. That is because of in law, the effective date is December 31st, 2026. I believe that is interpreted to mean that they go into effect on January 1 of 2027. But I wanted to maintain the effective date of the 2026 as it was written in law. I will note that there is also a ability for states to apply for a good faith waiver, since technology systems are not always able to be performed in a timely fashion. There is no information from our federal partners on what that may look like at this time. In the SNAP world, the administrative costs for the states is expected to increase in 2026, putting additional strain on the SNAP budget. Claire, do you want to talk a little bit about what's going on in the marketplace?
Sure. So for plan year 2026, there are a few changes to the marketplace program in terms of eligibility and operations. One of the key provisions here is removing caps that are currently in place for lower income consumers who now will need to pay back some or all of the tax credits they received to help pay for marketplace plans if the amount changes. So consumers who should have been eligible for OHP or OHP Bridge might face larger amounts owed, and other consumers who are tax credit eligible, but who reported income on their application that is significantly lower than the income they reported at tax time could owe large amounts. So we will be working on educational and communication materials to make sure marketplace enrollees understand the consequences here and ensure that they are submitting accurate information to minimize the chance of needing to owe repayment amounts. There are also changes to provisions, including the definition of all high deductible health plans. These will now include marketplace bronze plans, which will allow enrollees to contribute to health savings accounts when enrolled in those plans. And then also in 2026, there's a provision ending tax credit eligibility for non-citizens who have been in the US for less than 5 years and would otherwise be eligible for Medicaid, sometimes referred to as the 5-year bar population. So those consumers will not be eligible for tax credits, but can still purchase full price plans from the marketplace. All Oregon residents, regardless of immigration status, can continue to purchase individual plans directly from insurance carriers. Emma, next slide.
Excellent. Great. That changed to the redetermination every 6 months for adults. I want to specify the work requirements and redetermination policies are for adults that are in a category of eligibility called the Medicaid expansion eligibility group, which is adults aged 19 to 64 who are either parents or and have a little bit higher of an income and or who are don't have children and don't have disabilities or don't meet those disability criteria. And by disability, don't have disabilities, I mean don't meet existing eligibility criterias that are due to disability. And so it's a very particular set of people that will be eligible for these or required to meet these new requirements. But for children and adults with disabilities, the changes around redeterminations from 2 years will or 0 to 6 will move to annually for people that are outside of that Medicaid expansion eligibility group. I will also note that there's going to be a change to retroactive coverage. Currently, Medicaid, when you apply and say you had very expensive medical bills in the past 90 days, Medicaid will pay for those bills that before you applied for coverage. That will change to either 60 days or 30 days, depending on the category of eligibility that you are in, starting in 2027. The monthly allotment for the SNAP program will be amended in 2027. And I think Claire kind of mentioned this in another slide, but if there's anything you want to share here around the premium tax credit eligibility for non-citizens.
Sure. I'll just note that there are additional changes to the eligibility definitions going in place in 2027. So again, part of our focus here will be on really helping through our insurance agents and community partners and brokers, making sure they understand These changes, this in 2027 specifically changes the definition of lawfully present to include most asylees and refugees. So those consumers will no longer be eligible for tax credits on the marketplace starting in 2027.
Next slide. Some more changes in 2028 that are coming. One is related to long-term services and supports. Currently, a person who has a house, the house is not necessarily included all the time in their determining their eligibility. But this adds a new cap on the home equity that a person can have. The idea here, I believe, is to ensure that people who own multi-million-dollar homes are not using are not becoming eligible for Medicaid necessarily through the long-term services and supports programs. There is a new option that was included related to home and community-based services, which provides long-term services and supports within a home or community setting. Previously, in order to qualify for what are known as 1915C waiver programs, a person needed to have institutional level of care, which has the incentive essentially of somebody having to go to a nursing facility or other institution before becoming eligible for home and community-based services, or may have that incentive. Which if somebody first lives in a nursing facility, they may no longer have their home and community to return to necessarily. And so what this would do is change that so that somebody doesn't need that institutional level of care necessarily. And this could provide a significant amount of additional people home and community-based services and supports. Starting in 2028 as well, Medicaid members that are in that Medicaid expansion eligibility group and who make over 100% of the federal poverty level will be eligible or will be required to pay for certain Medicaid services as a copay. Currently, we do not have copays in OHP, and this would add additional copays. In the SNAP program, there's additional financial penalties to states for having error rates for eligibility that will become in effect, and the federal government will adjust its share of SNAP benefits cost based on that error rate. Claire, you want to explain what's going on with the re-enrollment?
Absolutely. So in 2028, this provision will end auto re-enrollment, which means that marketplace enrollees will be required to verify their information each year before enrolling in a new plan. That's different from current policy where enrollees can permit healthcare.gov to use information available from the IRS to automatically update their tax credit eligibility and enroll them in a plan in the next year. And currently about 30% of enrollees in Oregon allow themselves to be automatically re-enrolled. So this will be a change impacting about a third of marketplace enrollees, and then additional folks that are coming onto the marketplace who will need to do that active re-verification each year.
Great. Next slide. Finally, in 2029, there is going to be a new system in place to prevent people being enrolled in multiple state Medicaid programs. There's a system called PARIS. There's a lot of fun acronyms in Medicaid that spell different words, and apologies for getting them mixed up. The PARIS matching system has it tells states when somebody is enrolled. There are a lot of issues with that. It's run by the federal government. So the federal government will have a new process to make sure states know when somebody is enrolled in multiple different states so that we can ensure they're enrolled in the correct state that they live in. And then I will also flag that the perm process is something that as we determine somebody's eligibility for Medicaid, if that is done in error, it is what is known as the perm. I apologize, please, for not knowing what that what that acronym spells out, but or I do, I just don't remember at this moment. But there will be new penalties associated with having a higher error rate in that eligibility processes. I believe that's all the slides that we had today. Oh, sorry. It is not Claire. I apologize.
No worries. Yeah, and this is just a different slide with a different bright color. To note that what we were speaking to previously were changes that are a part of HR 1. At the same time, on the marketplace side, CMS issued a final rule called the Program Integrity and Affordability Rule, which has a number of similar changes as HR 1, but putting those into effect at earlier dates. And some of those are described here. The current complicating factor is that Oregon, along with other states, brought a case against the federal government to against this final rule. And the federal district court for Maryland stayed the effective date of a few of these provisions. And we are still awaiting a final decision on that case, which will inform what type of changes are actually going into effect in 2026. So this is what is in the final rule, but again, we're waiting for the courts to make the decision. What we do know, however, in 2026 will be another large impact to the marketplace is the fact that Congress failed to extend the enhanced premium tax credits, which were in place for the past few years since the COVID pandemic, and were providing additional financial assistance to consumers at more moderate income levels to purchase plans on the marketplace. And so those are scheduled to sunset in December of this year if Congress doesn't act to extend them, meaning that every subsidized marketplace enrollee will pay more for coverage. We are expecting for folks that are between 200 and 400% of the federal poverty level, that could mean increases in their premiums of between $90 and $165 per month. So pretty significant increases. And older enrollees over 400% of the federal poverty level could pay much more per month, upwards of $900. So we are continuing to watch what's happening as this continues to be debated in Congress, given that it wasn't included in HR 1, and will create a pretty significant cliff for consumers in 2026 on the marketplace side at the same time that eligibility changes are happening across the board. And I think that's it, Emma.
It is. Thank you.
Well, thank you both. We have about 5 minutes for discussion remaining. MAC members, do any of you have questions for our presenters? Heather.
My Zoom is being slow to respond. Apologies. Yeah, not so much a question, just a clarification. On redetermination for and both my questions are kind of around the work redetermination. Every 6 months, that's great news. Oregon's gonna stick with the minimum. Thank you, team. And my question is, do you know at this time, will individuals have to submit their proof of work? Those that have to submit proof of work, will that happen every 6 months, or do you know if that has a different timeline?
Yeah, so we are doing a lot of work to analyze how this was going to actually work for individuals in Oregon, and it is very much at the early stages. The federal government has a lot of work to do to explain what is allowable and not allowable under federal law to states at the same time, and we have not gotten any guidance from CMS on how those rules would be applied. But essentially, the way the law is written, the way the statute is written, is that somebody would need to make that would need to prove work on a 6-month basis, unless the state is able to verify it through other means, such as tax information from employment information that the state gets already.
Thank you. That's super helpful. And
Or other sources of information. There's, for example, exemptions for certain populations like students, and how we can try to get information from universities and other things like that is exactly the work that we're trying to do to make sure that we have the most updated information.
thank you. Boy, that's a huge lift.
So that it's not where we are focusing is trying to ensure that this is not a lift, an additional burden on our members, that we are able to do as much as we can through IT systems and confirming information, without individuals having to make those proofs. That being said, we have done a significant amount of work on that due to unwinding. But this is very, very complicated, and we don't have any of that federal guidance.
Thank you. And then my other clarification, just one more, was for adults with disability, have you received pretty clear or clearer definitions of what that may all encompass?
Yeah, so adults with disabilities, if they qualify for certain disability eligibility groups, so folks that have Social Security income disability and SSDI, or somebody qualifies through certain programs in our in other Medicaid eligibility categories. If somebody is essentially enrolled in a different eligibility category beyond the Medicaid expansion eligibility category, they are not subject to the work requirements. However, we know that those thresholds for disability for people, like you can have a chronic condition or a severe a health need, and not qualify for Social Security disability or some of the other eligibility groups. You may not have institutional level of care or other high levels of care need that would qualify you for those Medicaid programs. But it may be may make working 40 hours a month very challenging, or sorry, 80 hours a month very challenging, and thus there are some exceptions for people that meet medical fragility definitions. There is no current federal definition for medical fragility, and that is an area that we are in really deep discussion with the federal government.
Well, thank you. I'm sorry, this is really specific in the substance use disorder. I know there's still some back and forth, but from what you've said, institutional level care, maybe medical fragility, et cetera.
And engaging in substance use disorder treatment is another exemption. And if you want a full hour of me talking about exemptions, I can also put in the chat. I recently gave a presentation from KFF, formerly known as the Kaiser Family Foundation, along with the Utah Medicaid director and the current individual in charge of Medicaid at the Trump administration. And you can see greater depth on this topic, as well as some analysts that give more in-depth overviews of the policies.
Thank you so much, Emma. I really appreciate all your hard work on that. Thank you.
Okay, we'll have one more question from Tony, and then we'll move to our next presentation.
Yeah, thank you, Claire. Thank you, Emma, so much for the presentation. A lot of moving parts, and I feel like we all need a PhD to understand all of this, and I appreciate your insight and highly recommend everybody to check out Emma on that Kaiser Family Foundation presentation. Very informative. And also just a big thank you to both you and all your teams and all OHA is doing for right now. In these troubling times, trying to provide good quality information and clarity to our community as well as, you know, the health system more broadly. So just big thank you. Mine is a bit related with the new changes as far as reimbursement to CCOs, as far as increasing capitation rates. I really appreciate the attention that is obviously in response to concerns of decreased funding. One thing I would just like to call out is the observation, a little bit of some clarity in trying to do some investigation on how that impacts FQHCs being on a PPS rate, and a consideration if that will increase as well. And we may not know the answer right now, but I know as quality incentives go down, if those rates aren't impacted in PPS, then in essence, FQHCs might stand to lose and total payment. So I know that there is some upcoming conversations about that. I don't know if you have any thoughts on that at this point, or anything to learn, how we can discover that further.
That is a great call out, and one that I'm actually going to need to take back to the team to get any additional specificity on to answer your question more fully. However, I will broadly, if our chair allows me the additional time.
Yes, of course.
Thank you.
I'm also interested in this question.
I appreciate the question on CCO rates and 2026 processes. There's been a little bit of news in that, and I'm actually going to ask my chair if maybe that this is a good topic for our the next MAC meeting. I don't want to go too much over time, but what I do want to just say is that we are committed with working with all of our partners across the state, and ensuring that we are working towards our goals of ensuring access to real healthcare services for our members, and in ensuring that we are providing high quality, affordable healthcare to the healthcare system as a whole. I'm very conscientious of time and know that we've got a lot of presenters here and the rest of the meeting today, so I don't want to go too much over, but I think that that's probably a great discussion for one of our next meetings about exactly what work has been done and some of the changes that are coming in the 2026 contracting year.
Thank you, Emma.
Sarah, perhaps you could make a note of that I believe our October agenda is pretty full already, but perhaps for our December agenda, we could consider that. So
Yeah.
thank you, Emma. Thank you, Claire. Thank you for the questions. So we will move on to our next agenda item, the Beneficiary Advisory Council update. So the Advancing Consumer Experience Subcommittee has evolved into the federally required Beneficiary Advisory Council. Lydia Dennehy will be leading this update today. So thank you, Lydia, for joining the MAC and back and being here to present these updates today.
Great, thank you. So we had our first meeting and earlier this month, and I'll give you an update. So next slide.
I don't believe our slides are sharing. Tom, are you able to share the slides?
Yep, they're here. So the Beneficiary Advisory Council, I'm seeing them. Are you guys seeing them?
Can see
I
them.
can see them.
Yeah. Okay.
Apologies, I was not.
That's right. So the Beneficiary Advisory Council is made up of people who are actually receiving Medicaid benefits, or are caregiving for somebody who's receiving Medicaid benefits, or are former Medicaid beneficiaries. And part of our role is to inform the MAC, and by July 10th of 2027, we will be 1/4 of the MAC as far as the membership. So the MAC members will include more beneficiary. Next slide, please. So we are one, yep, sorry. So we are next to the MAC in that we both advise the Oregon Health Authority directly and interact and are part of the MAC and try and give lived experience as part of the feedback loop to the Oregon Health Authority and to the MAC. Next slide, please. So we formed in July of 2025. We met on September 5th. We're one of all every state, so there are 50 BACs around the state. So we're made of Medicaid beneficiaries, their families, and caregivers, and we share membership with the MAC. We meet at least a week before each MAC meeting, and we elevate the voice of people who rely on OHP. Next slide. So our first meeting went well. We had a nice turnout. We had a group agreements discussion, basically similar to the ones at MAC, but stepping forward, stepping back, listening, being respectful, all of the things that make a smooth and inclusive advisory council. We did a beneficiary roundtable, so each of us shared something that was of concern or a kudo that we had for OHP. And then Emma came and gave a welcome and an update on what's going on for OHA. Next slide. So these are some of the points that beneficiary members brought up. So a caregiver faces care coordination issues because the release of information forms aren't valid across physical, mental, and dental health, and requests a cross-systems release of information form. Member received shabby treatment because provider assumed a lack of knowledge of the system because the member speaks Spanish, asked the provider to take equity trainings. Member's therapy office is repeatedly denied claims months after an appointment when peer support provides service instead of the therapist, stuck in a cycle of authorizations and denials, and just unclear why, and it's destabilizing for the member. I guess the therapist needs to take leave and the peer support person steps in to provide the services, and then the therapist is left with a denial and then can't pay the peer support person. Next slide. A member and advocate for the disability community hears about and experiences long wait times for wheelchair repairs, leaving them unable to do day-to-day things. Can OHP give mom and pop shops the ability to repair, especially in rural areas? Recent right to repair law may have opened new possibilities. If your wheelchair can't leave the house, then you can't leave the house, was their experience. Two members shared related concerns about the existing online directory, which may not flag which member practices are willing to take new patients or whether they are culturally specific. And then finally, another member shared about the lack of dental options for wheelchair users. The building might be accessible, and they may have ramps and accessible bathrooms, but the space it's where the dental work itself is done is not accessible. Next slide. A member reported being treated like a king at his dentist's office, and all members expressed gratitude for OHP and a desire to improve services for everyone. If you can go back, I'm sorry, the little diamonds reflect the max priorities regarding workforce aspects and network adequacy. Next, please. Next slide. We shared the Ombuds contact information to help members track down quicker solutions for the concerns that they shared, and shared comments with relevant program staff. And they're tracking to look for patterns and follow up. And this slide is Sarah and Tom's slide. This is what they're doing about what the back has brought to them. Next slide. And that's the presentation.
Thank you very much, Lydia, for sharing all of those updates and the conversation that you had in the back. Are there any questions or comments from committee members? I know I appreciate hearing both the specific positives and challenges. So thank you for highlighting both the very specific positives and challenges. Lisa.
Yeah, I just want to say how much I appreciate how many applications were received for the back. We were concerned because it was summer and, it's a new committee and we weren't sure how many people would show up, right? But it's really been encouraging to see how many people applied and how many parts of the state are represented. So yeah, I've been a part of this process for a long time, and I'm really encouraged to see people stepping up and people like Lydia taking over and carrying this forward. And yeah, I'm just it warms my heart to see that consumers are making the time to come and make their voices heard. So I'm hoping that it gets integrated into more of the state agencies, or sorry, not agencies, more of the state committees like OHPB and some of the other HERC and some of the other rulemaking committees. I hope that we continue to integrate consumers into those positions.
Thank you. And I will jump in and say there was a really good integration of our Spanish language and interpretation services and the ASL interpreter. So that was nice to have equity and inclusive, not only per different parts of the state, but different groups represented within the committee.
I'm glad to hear that that was a success. Other committee member feedback or thoughts or comments or questions? If not, then I'll open it to the public. If there are any members of the public who have questions or comments about the Beneficiary Advisory Council. Well, if not, then we can move on, but I just want to thank all of the members of the Beneficiary Advisory Council and especially reiterate Sarah's point in the comments of thanking Lisa for all of the work you have done, Lisa, for bringing the back to this point. So thank you so much for that work. And Lydia, thank you for being our inaugural presenter on the back to our committee here today. Thank you very much. I know we're a few minutes ahead of schedule miraculously. Are our presenters for the Board Registered Mental Health Associates presentation here currently?
We are.
Wonderful. So we have heard significant public testimony about this in the past, and OHA has asked for presentation and to get feedback and comments from the MAC. And so they are going to address in their presentation some questions that myself and Heather have posed in advance, and we will all have time to pose more questions, have more discussion, and this supports our focus on workforce aspects of network adequacy, specifically in the arena of behavioral health. And so today we have speakers Holly Heiberg of Medicaid's Fee-for-Service Transformation Director and Linnea Lindsay, our Behavioral Health Division Deputy Director. So thank you, Holly and Linnea, for being here today.
Thank you all for having us here, and we very much look forward to conversation and listening. I think this will be an ongoing dialogue, and you're going to hear a lot today about listening as really the essential part of how we move forward with this policy making. Just a small thing. I have a couple of titles. So I have Medicaid Policy Director and Medicaid Fee-for-Service Director. I think my team might have been exuberant by putting Fee-for-Service Transformation Director on the slide, but I just wanted to make sure you all knew what my official titles are. Next slide. So today, really, we thought it'd be smart to just take a little time up front, do an overview of the policy change, which we're in the middle of the listening component of for that change, our analysis of feedback, get to the questions asked, and then really open it up for questions. And we need to make sure we have robust time for that. So next slide. Next slide. There's a lot of pretty pictures in this slide deck. How we got here. I think many of you all are aware that Dr. Hothy, our OHA director, when she first became director for OHA, she went on a listening tour around the state and heard various concerns and asked us to begin a process to investigate and look at changes in the way we allow Medicaid billing for clinical social work associates, board registered marriage and family therapist associates, and board registered professional counselor associates. And again, I will say it about 10 more times, but I'll try not to be too annoying with it. So as a process to make policy change, we knew that there was a chance we could break a lot of things that were working, and we needed to do a pretty deep dive and understand where OHP members are, where providers are across the spectrum of behavioral health. We needed to really understand the system impacts. And so we laid out a process that involves careful listening and trying to manage some very complex levers in our healthcare system. Next slide. So the specific concerns that we've heard, we really heard clearly our community mental health programs and our coordinated care organizations are very concerned that the current policies are incentivizing the workforce to work outside of CMHPs, community mental health programs. And that is an issue because our community mental health programs are there to really serve as a safety net, to serve many of our friends, family, OHP members that are having acute needs in behavioral health and may not be served otherwise. And when our CMHPs cannot retain a workforce with experience and supervision, we aren't serving the people who are most vulnerable in our systems. So that is real, and we need to really figure out among the various policy levers how we help support and bolster a workforce for CMHPs. We also heard from the CCOs in particular, but we have also gathered from various partners that Dr. Hothy listened to throughout that listening tour, that there are concerns about quality and the consistency of quality and supervision standards for behavioral health associates and other behavioral health professionals. And we'll talk a little bit more about that and what we've been looking at, talking to the licensing boards, talking to various providers and organizations. There are some pretty big inconsistencies in our definitions of supervision and how it's applied. So there are some things in there we definitely need to look at across the behavioral health spectrum. And I think this is pretty critical. As soon as we said, hey, we're going to be taking a look at this policy, very quickly and very powerfully, we heard from various communities. We heard from communities of color. We heard from immigrant community. We heard from LGBTQ community. We heard from people wide and far that the current practices that allow behavioral health associates to serve OHP members has really opened up and allowed access to behavioral health services that weren't otherwise available in a way that people would seek care. So we're, again, trying to be thoughtful. We don't want to see people lose access to services. We want to perhaps add more structure, consistency, and quality and supervision standards. And we definitely need to look at how the most acute people in our communities are being served, making sure we have the right workforce for that. Next slide. So you're probably saying, well, how are you listening and how are you gathering data? So we made this timeline. And this timeline is tentative because as we do one step, we find out new information, and then we take the next step. And we are moving at the pace that our systems and community partners are moving in forming this policy. So we did work on some internal analysis of behavioral health workforce incentives and supervision. Linnea is going to talk a little bit more about that. We listened to the Health Equity Committee of the Oregon Health Policy Board and their recommendations and concerns around a blanket policy or some form of really just holding COA or non-COA as the way we would move forward. There was behavioral health legislation to be considered. We are in the middle of receiving feedback. We've got roughly 2,000 providers that have filled out a survey to give us information and insight on how and what kind of policy would be helpful in achieving those goals and what would not. And then we are launching the member feedback and holding engagement sessions. That is really the month of October. And then we will lead to further analysis and move forward at that point once we've fully listened and provided people various kinds of opportunities to provide input throughout this process. And we are really trying to be transparent about this process and put out the major milestones so that people can see how we think we can bring various points of view into the process over time and make sure that we're gaining knowledge, data, expertise, and experience throughout. And with that, I am going to turn it over to Linnea.
Good morning. Thank you for this opportunity to talk about a process that has engaged a lot of us within OHA, both in Medicaid and the Behavioral Health Division, and the work that we do with our community partners. This is, I think the best way I would characterize it, it is sometimes we think about approaching something with the tools in our toolkit, and the subtleties and nuances of this have become much more clear as the process has evolved. And we appreciate this opportunity to talk about that and to think through and hear from you all where your feedback and input can be helpful. The listening communities and things that we're engaged in from January to May, we're looking at, as Holly talked about, these workforce incentives and the certificate of approval. Thank you, Lydia, for asking the question. I did put in the chat. The definition of a certificate of approval is for a behavioral health organization, and it's issued by the Behavioral Health Division's Licensing and Certification Unit. It is a process, that there's a packet, there's all kinds of criteria that are involved in it. And we can talk about that further as we go along, as people are curious. The workforce initiatives that we looked at were the House Bill 2949 from 2021 and 4071, which was in 2023, which directed $20 million to help Oregon CMHPs offer workforce incentives tailored to their local needs. And there was early data indicating how many people were able to be incentivized with bonuses, stipends, training, tuition assistance, as well as increasing supervision. They were directed to support the behavioral health professionals serving this most vulnerable population. Yet the feedback still in 2024 was that those incentives, as they were still rolling out, they weren't all out the door, had not drawn enough of a workforce back into the county mental health programs serving this seriously mentally ill. There were still not enough workforce, and capacity issues have been a really important part of service in the work streams as you think about the services we deliver for the most acute patients and clients, and then how do we serve members at other levels of care. We want to make sure that our people in the workforce within the counties really have a sufficient workforce so that people don't end up in more acute settings because of lack of services at the time they need them. The certificate of approval is for outpatient mental health and addiction programs, including substance use disorder and problem gambling. And they have to meet some minimum health and safety requirements. There is regulatory oversight. There's facility inspections, review of their policies and procedures, chart reviews, personnel record reviews, fire marshal inspections, liability coverage confirmation, and when there are complaints and critical incidents, it allows us to be able to go to those organizations and work with them around those concerns. Um, part of the health equity recommendations were that there really has been workforce incentives brought forward. A key priority in the investments around health equity in the workforce were around delivering culturally and linguistically specific services to communities most impacted by health disparities, in line with our 2030 goal, strategic planning goals as an Oregon Health Authority. And it's really that to eliminate health inequities by 2030. We noticed that about 70% of our resources were going to non-white providers, and 52% of students awarded tuition assistance and scholarship through partnerships were also identifying, and the people involved in the 8 master's degree programs identifying as non-white, which is really moving. Those workforce incentives have been moving the workforce forward to better meet and be enable members to have providers who are culturally and linguistically trained, sensitive, and competent to deliver the care. And this is what our ongoing commitment to the work is. We want to make sure that people are accessing care as early as possible with people who have the ability to meet their needs, see their needs, not pathologize culturally specific concerns, and to really be able to acknowledge what they need in the moment where they are. And a lot of folks, the other place where we are really concerned is about people having services in rural and frontier communities, being able to access care, and being able to reach out to the CMHP in those communities really is a hub of the work and the workforce, working with community partners, but really working across those agencies. There was more that came in the 2025 behavioral health legislation. There's more workforce incentives, and an additional $5 million was awarded for scholarships, tuition assistance, loan forgiveness, stipends for students. And then another $1 million is included in the United We Heal Medicaid payment program that focuses on behavioral health workforce recruitment and retention strategies. It also creates new behavioral health workplace safety requirements and protections. And the aim is, again, to reduce barriers to entry for the behavioral health workforce and strategically prioritize historically underserved communities. And there is also a Senate bill that monies were given to Oregon State University's extension program on a behavioral health promotion project that will hopefully reach out to communities, rural communities, to convene community leaders and really look at where the gaps are in service, and look at the current services, gaps in services, and create some action plans. And then House Bill 2208, the community health improvement plans, it was requiring CCOs to collaborate with community mental health programs and local planning committees to develop their CHIPs, their community health incentive improvement plans collectively. That includes behavioral health into those programs. And an additional piece is the $48 million to expand certified community behavioral health centers, the CCBHCs, that was awarded and that fund expansion that was awarded out of House Bill 4002 in 2024. We have plans to add an additional 15 CCBHC clinics in 2026, which extends beyond the current 12 that exist. We have workforce dollars going into school-based health centers. And so there's this really a bolus of work that is evolving that occurred now, which again was asynchronous from when this policy memo was issued in January. We've learned that these legislative initiatives not only made it through session, but are funded, and we're working to develop the plans for implementation. We continue the work of House Bill 2235, the Behavioral Health Work Group, which is working on incentives. And so there's many other factors that are now going to influence this work, and just giving you kind of a survey and an oversight of that, so that you understand kind of where we are now in September of 2025. There's many multifactorial influences that have come to light and come to fruition at this moment. And we wanted to really robustly engage in feedback from providers and members around access to care and services kind of in a current state, which is a part of why we did not, typically rules implementation takes 90 days. And if we were to initiate rule changes on January 1, we would have to already have completed our engagement process by October 1. We know that we're not going to do that because we have slowed the rollout of this to really take in what happened legislatively, and to take in what this provider feedback survey is providing, and to take in what member engagement will be over the month of October, and then taking November and December to really bring all of those factors together and think about what the best rulemaking could be. So next slide, and then is really the next slide. Yeah, and the one beyond that, please. So you can see that there's all these emerging provider feedback themes that are happening. We wanted to give you a brief overview of what has been evolving from the 2,100 surveys that we've received. And again, that survey is open till the end of this month. So you can see that access, equity, and inclusion's right up there. Financial and provider wellness is up there. Policy rollout and timeline, which we're addressing, is there. System level and foundation change, process and administrative efficiency. We're really trying to take all of these factors in and really make sure that we're looking at them, and then supervision and care models. And I want to reiterate something that Holly mentioned. I'm a clinical psychologist, so I just explain that. So I know what my licensing board sort of requirements are around training and trainees, and I have led a training program previously. And so one of the opportunities that we took, because we're talking about board registered associates, and at the individual licensure level, they are under the accountability of their board, whether it's the social work board or the counseling board or the psychology board. The psychologists are not included in this, but the three board registered master's level associates we're talking about really have their supervision codified under their board. And as we looked across those three boards set of requirements, they are inconsistent with each other. Some are more, have more, some have less, some allow the supervisor to be within the agency or the organization where the person works, some allow them to have an outside supervisor. And then I just want to note, so we're not disingenuous, that under the COA approval, supervision can happen for somebody from a qualified mental health professional who doesn't necessarily hold a license, and that supervision is separate from the supervision that somebody is under who is going for licensure, and what their board requires and their supervision and their reporting to their boards. So again, the complexity of this becomes more apparent as we look into it. So really wanting to note what the emerging themes have been in this work, and then wanting to now move on to the next slide, because our time here that was really most important to us was to engage with you and really look at what your questions are and be able to be responsive, and also learn if there are additional questions or concerns that are emerging. So next slide, please. We understand that the questions that were posed that we're here to talk about today are: what are the requirements for board registered associate behavioral health providers billing Medicaid in other states? How are other states auditing board registered associate behavioral health providers? And does OHA have a plan for tracking health equity of OHP members? So those are the three questions. Hopefully we've set out a lot of background data that can help us to be able to be responsive here. So want to pause for just a second to take a deep breath. And Holly, do you want to respond to the first one? I can do the second one. You can do the third one, or how do we want to? Or do you as Mac want to ask us these questions, and we can see how we have some responses?
I
think
go
I
for
was
it,
going to
however you want to do
say,
it.
if you just want to go through them, that would be
Okay.
fantastic. Thank you so much.
We can
Appreciate all
do
the background so far.
So just to be clear, the first question is a great one, and we've done our research with the Oregon Council of Behavioral Health and asking them about inquiring about this, and the National Council of Mental Wellbeing also we reached out to. There isn't another state that expressly allows independent services by unlicensed providers. So this has been a unique and this goes back about almost a decade that the Medicaid decided that board registered associates could bill Medicaid as if they were independent outside of an organization, an agency, or a COA. So this is a unique trait to us in Oregon.
Lena, I had a question about that, and think that was one of my other questions, was when this started. And can you speak to why that happened approximately 10 years ago?
I can. I've been here at OHA 9 months, so I just will tell you that too. My understanding at the time, because I did work in hospitals and health systems and openly within here in Oregon, there was an access problem. There has been an access problem for a long time to meet the needs of the Medicaid population. And so the concept was that by opening the door, that there would be a better workforce. And we have seen, if you look at our data, there are more people being served. The numbers prove it out. But the idea at that time, my understanding, was to allow for more access to care.
I would also just add that one thing we did not mention, and that's in the sequencing, we opened it up, right? And then a handful of years ago, the legislature decided they wanted to support higher Medicaid rates for behavioral health overall. And they were significant. We are paying very competitive rates in Medicaid for behavioral health services. And we did see the workforce answer to that change in rates. And I think that was, really the lever that the legislature was trying to myou so that people in Medicaid could be served. They could actually receive behavioral health services. But I think when you add that to this mix, if we're paying, what incentives we're trying to balance this investment in workforce, competitive pay for workforce. And then we're balancing that too with the level of quality, expectation standards, supervision standards for that workforce, so that the OHP member is assured they're getting the best service they can. And I don't know, and I think it's like we'll never know, had we done the rates first, and I don't know if we would have needed to open the aperture quite the way we did, right? So we did it kind of in this weird sequencing where we were, I think, the only state that did what we did. Um, Certainly, that's what we have from the National Council for Mental Well-being. But it's not clear if the incentives in the workforce and the competitive rates would have moved us to a place for better access across the board. It's a little bit complex that way too. We're not sure which one of those is having the biggest impact.
And I'd also say, Holly, it moved not only the board registered associates, but it moved many licensed behavioral health professionals within the state to step into the Medicaid space that they had not historically been engaged in because the rates were considered low compared to what the commercial payers were. There's now more of a equitable, if not, and with some of the additional add-ons, at times now Medicaid pays more than commercial, and definitely more than Medicare rates. So that's, we've typically had difficulty with access for both Medicaid and Medicare. People who have those as their primary payer. So many people stepped into this space, and that the rates were a big shifting mechanism that happened. So that and so we hopefully that answers that. And if we want to loop back around, any other questions around that? And Heather, thank you. Yes, the most Medicare and commercial payers do not contract with with people who don't hold an independent license typically. So this is the board registered associates, I think, moved into this space with Medicaid because they were allowed to bill independently. And we did see people move to semi private practice kind of models. And I think it'd be remiss to not note that during the pandemic, a lot of people moved out of bricks and mortar and into telehealth or into more private spaces. And that also, I think, moved some expansion into this space as well, because it allowed somebody to be in a private space and to bill from their home even in delivering care without even having the overhead costs of an office. So that's
Tony?
Oh,
Tony?
thank you. Yeah, no, thank you for this presentation. I guess I just have more questions, and maybe this is a bit of the history behind this. Our intention 10 years ago with policy was to expand access with more people to provide the care. One of maybe I'm making a false assumption, but I would suspect that the process to open it up to associates was that allowing people to enter the work field, work in the space of an associate, but then earn, because really the distinction I think we're talking about is behind a licensed individual versus an associate is the hours of clinical time to kind of learn and be equipped with what we're talking about. Essentially, is kind of competence in a space of that delivery of care. I think of it analogously to myself as a family doctor. I went to med school, but then I had to go to residency, and I had to train and do that to deliver the care. Did we see with this policy change more individuals change from associate to license with this policy? And I don't know if that the question again being, was that part of the policy change in the past?
I don't
Oh, go
To be
for it.
honest, I appreciate that question because you know, I also had to do residency. So before I could or as you know, before you could bill independently. And so and that was a few years before this happened in this state. Um, I don't know that we have data tracking that more people entered the workforce. And because, you know, correlation doesn't make causation real here, it also may be the workforce incentives we've been delivering. There are other potential factors that may be influencing people to seek licensure. Um, Licensure was always valued, but there have been many people who could work at and people continue to be able to work at county mental health programs and in certificate of approval agencies and never seek a license. So it didn't change that you could not seek a license. I do think some people may have moved a little more quickly and then exited the county mental health programs because they could seek a license. But I don't know that we have the ability to pull that data without doing an additional survey that gave us a sense of what directionality was happening causally in this.
Mhm. That's great. And then I guess just one quick follow-up, if I might. Let's say somebody's been working in the space of an associate, they have been acquiring hours. I guess it hasn't necessarily always been under supervision, but how do
Sorry.
well, that's okay. um, are in as far as their work towards licensure, how are those hours counted? Is that, as far as I think that the mark is 2,000 to 3,500 hours, is that correct?
And some of that's been lowered by their boards. So just to be aware, and some can be pre-degree and some post-degree, depending upon what degree you hold. And this is where the inconsistencies are. And for a board register associate, those are codified by their supervisor and submitted to their board. So those aren't, and whether they're obtained within an organization they're working with or in a practice or somewhere else, that it's under the responsibility of the licensing board. It isn't under the authority of the Oregon Health Authority and/or Medicaid. So that's a part of the disconnect too. And I think that was a part of the impetus to try to bring people under certificates of approval, because that is under our authority to really look at and review that work. So again, those are tracked and licensed, and it's between the supervisor and the supervisee, the associate, and the submission of data to their board.
Thank you. Very helpful.
Certainly.
Thank you. Yes, it's like Tony, I'm a family medicine doctor, and it is very interesting to me as well to be able to bill at an independent rate, whereas going through residency and Linnea as well, if you, I'm sure, also recall that the pay is not the same in residency. And so this concept was very interesting to me to be able to receive the full independent fees. So the idea of the chicken versus the egg that you were mentioning, I'm not sure which of you was saying that, I apologize, is an interesting idea.
I
So
appreciate
thank
that.
you.
Yeah.
It
I
is.
was behavioral medicine faculty in a family medicine residency clinic for 5 years. So I very much know the pain of residents and residency, both for physicians and for psychologists. So this is a different way of looking at it. And I think the two pieces I think that was unknown. When I stepped in a couple months ago to support this work, bringing a lot of that to the surface, that isn't, there's different ways to look at this, and a large, I'm just going to be frank, that a large question I ask is, what are we trying to solve for with this action? Because we need to be very clear about what we were trying to solve for. And for clarity, what we were trying to solve for was having a workforce for the seriously mentally ill. And there may be additional tools and additional ways to continue to support that and incentivize that. And we're looking at, and so we're doing a deeper dive and really trying to listen to make sure that we're getting to the why of this along, so that we don't, and noting what the potential harms may be, particularly for underserved communities of color, people who've been marginalized, and the work that we're doing around culturally and linguistically specific services, and really wanting the workforce to more reflect the population we have and that those needing access to care. So all of those pieces all together, I think, have moved us in this direction. I want to make sure we don't, we weren't sure we'd fill the time, but I think we're going to do well. This auditing of behavioral health providers is again done by their supervisors, by their boards for an associate. Other states audit those things because they'll audit the supervisor, that they'll make sure that that is reviewed and codified. But that is different if somebody is a board registered associate but working in a organization that holds a certificate of approval, they would also be subject to the auditing that's done under the certificate of approval, which includes many of the factors I spoke about earlier. So again, other states don't have auditing, again, because they don't authorize this type of billing. They don't have a separate track for it.
Heather?
Heather?
Yeah, Lenny, and I mean, so my comment on that, just to expand, I don't think everyone's quite intimate necessarily of the differences between being, and I think this goes back to Dr. German and co-chair Carolyn Barrett's comments, and yours too, about the importance of those basically residency requirements. I'm a licensed clinician. I did those too. And if you're working independently, you're not getting the same audits because you're historically, because you were licensed, therefore you've been through that process already independently, that you have in a COA that are Medicaid compliant, which are the chart reviews, the other safety reviews, fraud, waste, and abuse reviews. None of that is happening for the individuals working under this mechanism that Oregon allowed for the last 9 years-ish or so. Or so, I'm not even sure, is it somewhere between 8 and 10? So I think that's really, to your point, professional development and safety are, there's some big gaps.
Yep.
So thank you for taking the time and looking at that. We appreciate it.
There was one more question too on this slide, and I just want to make sure we address it. So we are collecting some baseline data before we make any changes because of many people in this room. We have really great laws in Oregon about gathering real SOGI data. Thank you for those of you who made that happen. And that gives us the ability to kind of look across right now and set some baselines. But there is a caveat to this. We just heard from our HPA director and Medicaid director on all the things coming. And so, unfortunately, we won't be able to say, hey, this is because of this, right? There's going to be a lot of different things that are creating change in our system all at one time. But we're going to do our best to try to track whatever changes we make here. And I think we will be making changes. I don't know if it will be the binary, you're in a COA or out of a COA, or if there's a new structure of some kind that will be between those as options. We have a lot to work on, but we will be tracking as best we can what is happening right now and what it looks like 6 months after we make a change, what it looks like a year, and what it looks like 5 years after. So we do have that as part of the work.
Thank you for specifically addressing that plan for tracking the health equity markers. And I really appreciate again, the focus on competency and goal of reducing harm. Again, coming from the lens of having done residency and been an intern who was fresh out of med school and didn't really know what I was doing, the idea of practicing with minimal supervision is scary, and can really do harm if you don't know what you're doing, and that applies to therapy as well. And so I think having more oversight and more rigorous supervision is a very worthy goal. So thank you for doing this work of helping provide more oversight for patients who are OHP members. We have about 5 more minutes. Are there other MAC members who have questions for our presenters? Are there ever any members of the public who have questions for our presenters? Lydia Danahy, feel free to ask your question, please.
I'm not sure. It's just more of a comment, but I want to push back a little bit that there are people doing really good work who are not licensed, and they may have a lot of lived experience in a specific culture or diagnosis. So yes, we want safety, but I do want to acknowledge that there's some really good work going on that before people are fully licensed.
And Lydia, I really appreciate that comment. And a large part of the work that I'm engaged in is making sure that our peers continue to be a part of our workforce and a part of the those with lived and living experience are at the heart of what we know and what we do. The Office of Recovery and Resilience is a part of my portfolio, as well as the Behavioral Health Metrics Committee and the Equity and Community Partnership for the Behavioral Health Division. And I also have quality assurance. So it's all kind of woven together that we want to make sure that those with lived and living experience are at the heart of this. This particular conversation was about people who were post-degree pre-licensure and doesn't, hopefully, isn't meant to reflect on any other part of the workforce.
Thank you.
Thank you, Lydia. I very much agree with that statement as well. Complicated topic. Andy.
Hi, thank you for having that presentation. My name is Andy Walsh. I'm the Senior Health Policy Advisor for Children's Institute. I'm also co-chair of the Health Equity Committee. I think I find it a little bit concerning that in that presentation, our report, a link to that report wasn't even shared. So I'm going to put that in the chat. It has much more robust information than was provided in this presentation regarding the concerns around this issue. Including that Washington State does allow for this policy, and we continue to refer to these providers as if they're pre-licensed, and they're not pre-licensed. They have a first level license. And so I doubt any state allows anyone without that first level licensure to bill or to provide services. So I'm not surprised you're not finding that information. But if you look at what we're honestly talking about, which is a pre-licensed provider, or it's a first level, it's still a license, that changes the situation and what you're supposed to be looking at. And so Washington does this. I'm happy to put links into the chat directly to that information. But I'm also curious why, when we're talking about this issue, we're not mentioning the fact that harm has already occurred. Care Oregon already made this change. OHA's own data stated that the bulk of these providers were under Care Oregon, meaning the bulk of providers have already been told they can't provide these services and people have lost their providers. Eastern Oregon CCO is about to make the change as of October 1st as well. So I think for a lot of people with lived experience, I think for those of us on the Health Equity Committee, we have a really hard time hearing these presentations from OHA, not acknowledging that harm has happened and that we're talking theoretically when this has already been occurring. I'm curious what the legality of that is and why OHA hasn't responded directly publicly to the legality of whether or not the CCOs could make these changes prior to them making these changes themselves. So if you could please respond to that directly, I would appreciate it.
Thank you, Andy. I really appreciate you bringing that to light. What I want to be clarifying about is we don't have that first level of licensure in the state of Oregon. There is no first level licensure. That is something unique to the, because I've worked in Washington and Oregon, that is unique to Washington State and the way that they have people register. But we don't have that type of first level licensure. The boards don't call it a licensure, they call it an associate, and it is a supervision contract, but it doesn't give authority for at the board level for people to have first level. So I just want to have that be a point of clarification. So we were trying to be very clear of not comparing to Washington because it is a different system. But you are correct, they do have first level and second level licensure steps. We don't have that at any of our current boards. It's not called anything like that. So being mindful of that. You are very correct that a CCO has made a decision and others are looking to follow suit. They do have the ability to make decisions about their own panels and about the scope of their workforce. But we have been in dialogue with them around our concerns, and that they've stepped ahead of that. And because it is a sensitive conversation, it is not, we're not in a place to talk about what we're doing publicly at this moment to address those concerns.
Andy, I am sorry if that has not been clear about where CCOs can take action on their own by the prescriptive nature of how CCOs are formed in this state and what OHA can do about it. OHA, because of the global budgeting and the way the CCO structure for managing care works, they really do get to make a wide variety of decisions to meet people's needs and to balance their budgets. The tools in the toolbox at OHA when people have questions or issues or it feels disruptive. We've had, I could follow up, but we have a set of tools for monitoring and assuring network adequacy and monitoring the CCOs from that angle. But if that hasn't been made clear, I'm happy to follow up directly and provide some information about what we do legally have as tools in our toolbox as part of assuring the quality of care and access to care for OHP members.
Well, I want to thank Holly and Linnea for coming today and for everyone engaging in this really robust conversation. It's an incredibly complex topic, and I appreciate everyone's participation. We will, if there are further questions for Holly or Linnea, please drop them in the chat and we can forward them to Holly and Linnea and make sure they get them. Thank you for coming today. We will now have our break. We will break for 6 minutes and come back at 11:05 a.m. Thank you, everyone. A representation of the Medicaid Advisory Committee, its members, the Oregon Health Authority, or Oregon Department of Human Services. Each presenter is given 2 minutes to share. In the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the committee chairs and staff to determine the appropriate next steps. Committee staff will communicate the next steps with each public commenter. We have, I am looking at Sarah, that Sarah says we have multiple testifiers signed up. Do we have a list of the order, Sarah?
Yeah, so I would say we have Nancy, and forgive me if I get this wrong, Ewell, and followed by Judy Toxtad. And then we have 2 pieces of written testimony, which will drop into the chat as well.
Hey, Nancy Ewell, are you here and ready to testify, provide testimony? Not
Yes, I am.
testify,
Good morning.
apologies.
I'm ready to go.
Thank you.
Thanks. Good morning. My name is Nancy Ewell, and my pronouns are she, her, and hers. I'm a community volunteer helping 2 Rohingya refugee families settle in here in Portland. In mid-May, they each received approval from the HRSN rental assistance from Care Oregon, but the actual setting up of the rent payments has not happened. I spent days on hold with Care Oregon trying to get information about the process and when to expect rent payments to start. I'm sure you can imagine how stressful this is for the families. The mother of one of the families is blind. Because of her care needs, it's challenging for the dad to go out and find work. They have no resources, and each month they worry themselves sick on how they're going to pay rent. They know they have a promise from Care Oregon for the rent, but they don't understand why it's not actually being paid, and I'm at wit's end on what to do. These families meet the requirements listed in the OHA publication Housing Benefits for OHP Members. They've been approved for the rent payments, but what seems clear to me is that Care Oregon expects people to end up in eviction court before they will do anything. Why? Why would Care Oregon push someone to the cliff edge of losing housing before they will actually help? When people need support and lack resources to prevent homelessness, they need the help now. Everyone knows that the best practice to stabilize a family when they're still in housing is when they're still in housing, before eviction court, before a move-out plan, before homelessness. It seems like Care Oregon is using eviction courts as means testing. It's like using a sledgehammer to crack a nut. It's not good for the tenant, the landlord, or the court system. Nowhere in the published requirements does it say you need an eviction notice to actually access the assistance. It has an income requirement, it has a health requirement, and a needs requirement. There are simple, faster, and less damaging ways to confirm that information. I understand that making rent payments may not be a typical transaction for Care Oregon, but it's not hard to figure out. Social service providers do it all the time and follow proper means testing and accounting procedures. Care Oregon does not need to reinvent these processes. From MAC, I ask you to focus on 2 pivot points. Number 1, have them hire sufficient number of experienced social service providers to get the payments flowing quickly without the need for a notice from eviction court. And secondly, amp up the customer service capacity so people do not have to spend hours on hold with Care Oregon before getting through. It's unacceptable. Thank you.
Thank you for your testimony. Judy Toxtad.
Unfortunately, I prepared my comment for 3 minutes instead of 2, so I'm just going to touch on the things that are really important. So this testimony is about a woman. She's a victim of war. She's 35 years old, PTSD, multiple health, mental health diagnoses, and she ended up houseless with no belongings. I told her about the program that provides 6 months of rental assistance. She applied for the program and was approved. The rental assistance that was promised never happened. The message from HealthShare went from you are approved to you are approved and we are looking for a payer. And then you are approved, we are looking for a payer and we need a ledger from the landlord. The housing organization was Central City concerned. They knew about the approved rental assistance and the need for a ledger, but they continued with the eviction process. She went to court with the approval letter in hand and received an eviction, a court-ordered eviction. She's houseless today, in mental crisis, deeper in debt, with an eviction on her record, all due to this failed program and the lack of coordination from Central City Concerns. The last words from Central City Concerned, and I quote, "I do not have any emails requesting rental assistance information. We are no longer going to accept rental assistance. Good luck on your next housing endeavors." It's a cruel comment. You know she's coming out more in debt, an eviction on her history, and no way to get housing. So how do we rectify it? Don't start a program that promises financial relief without the means to support the program. If you have the means, then enact a solid operating procedures to support the program. Coordinate directly with the landlord. If you're working with a population that doesn't understand requirements, do not have a computer or online access, the results of this program will fail. The nonprofit housing organization should be able to support this mission and collaborate directly. So that's my 2-minute version of a written comment. So if you can be sure to read the full story, it would be very helpful.
Yes, you can absolutely submit written testimony of the remainder of your entire testimony, and we will read the entire testimony. Thank you very much for being here and submitting your verbal testimony as well.
Caroline, I will just point out that we have that written testimony and we dropped a link to it in the chat for anybody who wants to access that. Thanks.
Thank you. Do we have other members of the public here today to provide verbal testimony?
I see that we have a note from Jessica, and I'm assuming that's Jessica Israel, who had given us public testimony earlier. She's not in a quiet place and asked that her testimony be read. Ellen, are you able to do that, or?
Yeah.
Great.
I can do that. Ellen Pinney testifying on behalf of Jessica Israel using the testimony she provided for you all. I am a mother with 2 rare incurable illnesses, including a rare cancer. I first applied for HRSN housing assistance in December 2024 and was told the process would take 4 to 6 weeks. Nearly a year later, I am still waiting. I have spent hours on hold each time. I called the HRSN line, with one instance lasting more than 6 hours before I was finally able to reach someone, only to be told yet again to keep waiting. Multiple representatives told me not to pay my rent because funding was, quote, on the way. Had I followed this guidance, I would have been evicted, as has already happened to many, as documented by the Oregonian. A provider was willing to immediately fund my case under a single case agreement, but Health Share Care Oregon refused. A direct pay solution is also available and supported by OHA. Yet again, Health Share Care Oregon has declined to utilize it. I've been repeatedly told that nothing can move forward without an eviction notice, meaning I must risk homelessness before receiving a benefit I was already approved for. This is not equity. Equity should never mean that families must face eviction before being granted assistance that has already been approved and funding identified. I have exhausted every available channel to advocate for my family. I am going to leave it at that, Kali, because I think I'm probably close to my 2 minutes, and you have the written testimony from Jessica. Thank you.
Thank you for your testimony. Do we have other members of the public here for testimony today? So thank you to the members of the public who have provided testimony today. We will move on to MAC member discussion. We have lots to discuss today and 2 possible votes. Initially, we will start with the 2025 to 2027 work plan. So, Sarah, if you could drop that link into the chat. In your packet last week, we have the work plan for the next biennium, focusing on our 3 top priorities, which are protecting OHP eligibility, measuring 1115 waiver implementation, and workforce aspects of network adequacy. It incorporates work of the goals subcommittee, which include Heather Jeffress, Stacy Shaw, and Shannon Buck. Are there any discussion or questions on the work plan that was sent for review prior to this meeting?
I just want to, this is Kelly. I just want to call out that there were pieces within the presentation earlier in the meeting today that I think we talked about being targeted for the November meeting. And so just making sure there's space in this draft work plan that will fit into the schedule.
Are you speaking about the question about CCO reimbursement? I'm sorry, could you be more specific?
Yes, that was the piece that was asked about during the prior presentation.
Okay. Yes, and I don't have the work plan pulled up right in front of me. Oh, it's here. Sarah has it linked in the chat.
Yeah, I think we can, I can work with Emma and we can figure out how to work that into the plan either for October or December.
Yes, because as in November is an optional educational session, not the, we don't have a regular MAC meeting in December, in November, given the
correct.
Thanksgiving holiday. Yes.
And Emma confirmed. We'll work it out.
Great. Any other questions or discussion items for the work plan? Okay, then do I have a motion to approve the 2025 to 2027 work plan?
This is Lydia. I move to approve the 2025 work plan.
Thank you, Lydia. Do I have a second?
This is Jerry, I'll second.
Thank you, Jerry. Are there any objections?
No.
Any abstentions? The motion carries. We are changing the order slightly of our discussion from the agenda that was received by the MAC members. We're now going to move on to having Jerry report on the HRSN subcommittee recommendations. So I'll hand it off to Jerry.
Okay, thank you. Why don't we go to the next slide? And I've had the privilege of working on the subcommittee with Heather, with Sarah's support, and we met 3 times since June. And learned about background and benefit of the program, discussion of qualitative and the quantitative data. Next slide, please. And sorry. These are recommendations from that meeting. We'd like to turn over most of an upcoming MAC meeting to hearing from OHA, excuse me, about the HRSN housing benefit, including qualitative data on people served, or quantitative data on people served, qualitative data about consumer experience, status of solutions offered to address plan and community provider capacity, as well as communication shortfalls. And we'd like to provide significant time for public testimony, which I believe is what Ellen's asking for in the comment section. Next slide. And we asked several questions of OHA, which they have provided answers to, which we'll be going over at a future date. We asked the question of how much of the $900 million allocated for HRSN has already been spent, how sustainable is the benefit, and how will OHA track success of this benefit? Is the $900 million just for housing HRSN benefit, or is that for all future rollout of HRSN benefits like nutrition? What's left to allocate? Are HRSN funds protected for this purpose? And does this funding need additional support? Next slide. And we'd like to request regular updates at the MAC meetings. and to ask the internal HRSN group social health needs and analytics projects to update the MAC on a quarterly basis about data on people served, qualitative data about consumer experience, and status of solutions offered to address plan and community provider capacity, as well as communication shortfalls. Next slide. And we'd like additional engagement with OHA. Early MAC involvement with HRSN closeout plan. So how do we review how this program has worked? We clearly have heard about the shortfalls, and how do we use those examples to prevent this from happening in the future? And conversations between MAC and OHA to improve agency response to community concerns. Next slide. We'd like to invite committee discussion.
Thank you, Jerry, and also Heather and Sarah for all meeting together to work on this. My initial thought is trying to think of when in our work plan we would have time to dedicate a large portion of a meeting to discussing these subcommittee recommendations. Sarah, do you have any initial thoughts?
Yeah, sorry to be a disembodied voice. Here we go. Nope. I reviewed the work plan, and I think that there are some things we could move around in order to take most of the December meeting for this. We were already planning to have an HRSN kind of quarterly update at that point. So I think, that's already a chunk that we could dedicate to that. And then I think there's some things that were in the work plan, which I don't have up in front of me, unfortunately, that we could move around. I think if I recall correctly, there's a CAPS update that we could put off until January. And that would give us.
There is a CAPS update in
Yeah.
December, yes.
Yeah, and that would give us a big block of time.
Okay.
So I think we could do significant work in December.
Okay. Are there other items of questions or discussions? Do people feel like we are able to have a vote on these recommendations today, or do we need more time for discussion around these recommendations?
This is Kaya. I would like to have that meeting around HRSN in December if possible. I actually run the HRSN program here now. Just became the department manager for it. And I know things are changing starting January. So if we could have a discussion in December before the new year starts, that would be great.
I just want to also thank you, Kaya. I just want to do a time check. We do just have 6 minutes left before this meeting concludes, and we do have another item we do need to talk about as well. So Heather.
Apologize. I would like to hear what as a subcommittee member, and with the updates that we received today as a committee from the Ombudsman Office, I would like us to have a brief discussion if there is some way that we can support some of the recommendations that are coming from the Ombudsman Office as part of our subcommittee recommendation. If we can I apologize, co-chair, for asking for a little bit of discussion here, but I think it's pretty pertinent based on the information in the report that we had today on this ongoing work.
I am wondering if this just needs to, with knowing that we just have 5 minutes and needing to end on time to respect everybody's time, if this would need to get pushed to an October discussion is what I'm wondering, if knowing, because we also do need to, we still have to we have not recruited members for our ombuds report subcommittee. And so just to put that out there, I'm going to jump to that very briefly and then we can circle back. We do still need to recruit members for the Ombuds subcommittee report that we committed to in, please correct me, was it the May or June meeting? And we need to have one 1-hour meeting by October 15th with MAC staff, comment on a draft email by October 21st to 23rd, and then be able to report at, I believe, the October meeting. Is that correct, Sarah? Sarah is nodding. And so we are requesting an additional 1 to 2 people to serve on that. And Heather has already volunteered for that committee. So if you can respond to Sarah by email, we do need somebody to respond to that end of year report from the ombudsman. Sarah, how do you suggest we close out, knowing that we just have a few minutes left? We have Heather and Jerry and trying to also have more discussion around the HRSN topic.
Yeah, we've just talked about our work plan. I don't feel a great need to preview the October agenda. If we want to
Agreed.
take a few minutes, and I think we can skip our usual Rose
and Fun. Sounds good.
Yeah.
Okay. Thank you. Jerry?
This is allowed, but I'm wondering if the HRSN subcommittee could meet with the Ombuds program about these issues prior to having the meeting in December, so that we can distill some of the issues that we need to discuss in December. I think one thing that's really been missing for me, which is pales in comparison to the folks who are losing their houses, but the organizations that are trying to help these individuals stay housed are also experiencing a level of frustration, and the work that they have to go through on their end and talk with these people that are desperate and rightly so, needs to be considered as well, because there's a cost of doing that work over and over and over again as well. So I think that's a piece of this that's missing, and needs to be considered, especially in the outcomes or the closeout of this program.
So I think our question in our last 2 minutes of our meeting is if we're ready to vote on the HRSN subcommittee recommendations, and if we could go back to that slide of their recommendations, please, or if we need to defer the vote to our October meeting. And so are committee members feeling ready to vote, or do we need to defer further discussion to October? It sounds like we do have time to have a thorough discussion in December. Do other members of the MAC feel like they're able to vote, or that we need further discussion? Lydia?
I think given the urgency of the situation and the clarity of the recommendations, I think we could do a vote. I could vote today, and then we will have further discussions like on how to implement it in December. But
I feel comfortable with that as well. Does anybody not feel comfortable with that? Okay. Do I have a motion to approve the HRSN subcommittee recommendations?
this is Lydia. I will motion to approve the HRSN subcommittee recommendations.
Thank you, Lydia. Do I have a second?
This is Shannon. I'll second.
Thank you. Any objections? Any abstentions? Okay, the motion carries. So I will pass it off to Sarah for a brief closeout.
Okay, thanks everybody. We've heard a lot of we've had a lot of really powerful both presentations and testimony today. And a lot to think about and lots to continue to work on. And I really appreciate everybody's engagement. I don't know if we have time for Roses, Thorns, and Bud. Probably not. But if anybody has a last word, feel free to get it in quickly. And just want to thank all of the members of the public, especially who are here today and engaging with us. And I wish we could move faster. We're moving as fast as we can. Any comments? Last comments from MAC members? All right. Thanks a million. And we
Thanks,
will see
everyone.
you all next month.